The Train of 4 is a device we use to test peripheral nerve stimulation to determine the level of paralysis a patient is experiencing. So we use this device, the Train of 4, to determine how paralyzed the patient is. It's important for you to know as the nurse, before you ever start a paralytic, the patient will be sedated to your goal in therapeutics. So if your biz goal is 45 to 60, before you ever initiate that paralytic, you're going to ensure that that patient is sedated. Paralytics do nothing to dull your sense of smell or hearing or touch. So you can feel and hear everything around you and everything that's happening. So this can be really traumatic for a patient that's undergoing a therapy or procedure that's really invasive and often results in a lifetime of therapy and post-traumatic stress disorder. So make sure the patient is sedated prior to starting any paralytic. So the Train of 4 is a device that delivers 4 electrical shocks to the patient, and we watch what the patient's response is to determine how paralyzed they are. So your goal when you deliver these 4 shocks is to have 1 to 2 twitches out of 4 twitches. And you want the clinical goal to be achieved. What is the clinical goal? It's typically ventilator compliance. So you want the ventilator to optimize ventilation and take over breathing for the patient. So what you look for as the nurse is, are they getting their tidal volumes? Are they over-breathing the vent? Are they breathing what the ventilator is set for them to breathe? And are they desynchronous with the vent? Are they alarming it? If if they're getting too little or too much tidal volume, if they're over-breathing the vent, and if they are desynchronous with the vent, they're not achieving their clinical goal. There's research to suggest that early paralytic use during ARDS is beneficial and has improved outcomes, but using it in the later stages of ARDS and continuously using it has mixed results. So if you can achieve according to the AACN, if you can achieve your clinical goal without paralytic, then that's great. Or with less paralytic, you might have 3 out of 4 twitches and your clinical goal is achieved. Our order says and clinical goal achieved, so that might be something we need to look into. So you have the patient sedated, you're gonna start the paralytic, but before you do so, you need to establish a baseline called the supermaximal stimulation. The baseline is gonna determine at what milliamps you will assess the patient at every time after you start the paralytic. So you're going to turn the Train of 4 on, set it at the lowest setting, which is which is 10 milliamps, and you're going to watch the patient's response. You see a little bit of twitching with 10 milliamps, and then you turn up to 20, you see a slight increase in the vigorousness of twitches. So you turn it up to 30, you see an even more of an increase in the vigorousness of twitches. So you turn it up to 40, and now at 40, you don't see an increase in the vigorousness of twitches. You see the same intensity as you saw with 30. So then your baseline is 30 milliamps. If you were to have seen an increase in the intensity at 40 milliamps, then you'd go up to 50. And now at 50, you're not seeing an increase. So your baseline is at 40 milliamps. 2 things to note: if you're seeing a baseline between 60 and 80, if you're getting a report from a nurse who is has their baseline or is assessing them between 60 and 80 milliamps, it probably needs reassessed and reevaluated. Typically, patients are between 20 and 40 milliamps. I'm not saying it's not possible, but it's extremely rare. Also, once you have the baseline established before the paralytic, say it's 30 milliamps, you'll never increase the milliamps so long as you have that drip on and are titrating it. You would never go up to 40 milliamps, 50 milliamps. You keep it at 30, and that's what you use to evaluate your assessment. So if the next day you're assessing at 30 milliamps, you see 0 out of 4 twitches, the patient is too paralyzed. They have too much paralytic, so then you're going to turn and titrate the paralytic down according to your protocol. If you see 4 out of 4 twitches, the clinical goal is not achieved, then they are not paralyzed adequately. So then you would titrate up on the paralytic in accordance with your orders. Where to place the train of 4? You can place it over the ulnar artery on the arm, or you can, ulnar nerve on the arm, or you can place it over the facial nerve on either side of the face. A lot of people have questions about where to place the negative versus the positive lead. So the negative lead, which is black, is placed distally. So we see this middle picture, this is incorrect. This black lead right here is placed proximally. It should be placed distally, so you'd switch those. The red positive lead would be placed proximally. This is the opposite on the facial nerve. So on the facial nerve, the black negative lead is in line with the tragus of the ear, and the red positive lead is in line with the outer canthus of the eye. So one would think that this is distal and this is proximal. That's how I view it. So this is opposite. Black negative in line with the tragus, red positive in line with the outer canthus of the eye. So let's look at how you would perform that assessment. So we have 2 leads here. We're going to put it over our ulnar nerve. You can really get a feel for the ulnar nerve. It is really palpable. You want to place it right over the ulnar nerve. We're going to space it about 1 inch apart, 1/2 inch apart. Now your red lead is going to be placed proximally, and your black lead is going to be placed distally. So we have our train of 4 here. We are going to press the on button, and we see it says 0. You're going to turn up and down the milliamps here. Let's go ahead and crank that sucker back down to 10. And then you have your train of 4 button right here. So we have it at 10. And I'm going to hit the train of 4. We saw some twitches there, but not much. I'd probably have to turn it up. I guess I'm a little paralyzed. So then I would turn it up to 20. I'd press it. I'd see an increase in twitches. I'd turn it up to 30 and press it. I'd see an even more increase in the vigorousness of twitches. I'd turn it to 40. I'd see not an increase, the same as I saw at 30. So now my baseline is at 30. That's what I'm going to use to deliver shocks and assessments with the train of 4 throughout the patient's stay, so long as they're on that paralytic, and not take it, if they're taken off and 2 days later they decompensate and there's a need for it, you would reassess the baseline at that point.